Welcome back to this next video in which we are discussing kidney disease. So in the previous video we went over the four major categories of presentation of kidney disease, namely AKI, CKD, nephrotic syndrome and renal hypoperfusion. Before we move on and talk about causes, what I would just like to say is that these categories are not necessarily completely independent. Some of them can occur together. So for instance, we will see examples of diseases that can cause both AKI and nephrotic syndrome together. So don't think of the categories as necessarily being completely independent and not being able to occur together. Some of them can. Right, so let's now move on and talk about causes. And we're going to begin, as I said at the end of the previous video, with causes for AKI. So when we're talking about causes of AKI, we like to categorize it further, and we categorize it into three separate categories, and these three categories are pre-renal, which means that the problem is occurring prior to the kidneys. So it is a AKI that is caused by some sort of systemic problem, and I'll tell you the two major examples of that in a moment. Intrarenal, which is the problem is actually a disease of the kidney, and there are three major categories of intrarenal disease, namely glomerulonephritis, interstitial nephritis, and tubular necrosis, and we'll talk about those three in detail later on. And then finally, postrenal, which is some sort of problem with the urinary tract that is leading to an AKI, and we'll come on to that finally. So let's begin then with pre-renal. Pre-renal is really, really important to know because actually the major causes of AKI, and you see a lot of people in hospitals who are very, very sick with AKI, the major causes of AKI are usually pre-renal. They're the most common causes of acute kidney injury, and then it's post-renal, and then intrarenal, and we're going to spend most of our time actually talking about intrarenal because it's so complicated. Intrarenal is actually quite rare. It's quite rare for a disease actually of the kidney to occur. So be aware of that actually the time that we're going to spend on these different categories doesn't reflect how clinically common these different causes actually are. So let's change colour to spice it up a little bit. So starting off with pre-renal. So there are two major causes of pre-renal AKI that I want you to know about: dehydration and sepsis-induced AKI. And when you see someone in hospital whose renal function is going off acutely, these are the two things that probably you should think of first of all. So sepsis-induced AKI. So let's discuss them. So dehydration then. Dehydration means that the body fluid is too low. Blood volume is too low. This results in the proteins within the blood and other molecules within the blood becoming too concentrated. That is what is meant by dehydration. Too low blood volume, the proteins and other molecules within the bloodstream have become too concentrated. So the osmolarity has increased. What's that going to result in? Well, of course, it's going to result in decreased renal perfusion. If blood volume goes down, cardiac output goes down, and therefore the amount of blood going through the kidneys goes down, and therefore all the function of all the nephrons in the kidney is going to drop. The amount of glomerular filtrate that they're producing drops, and therefore the amount of urine they're producing drops, and therefore their ability to get rid of waste products and get rid of potassium and get rid of protons, all of that goes out the window as well. Of course, in this case, you're not going to have problems with fluid overload. So it's the exact opposite of fluid overload. It's fluid underload, effectively. So that manifestation of an acute kidney injury is not going to be relevant to an acute kidney injury caused by dehydration. However, it is counted as an acute kidney injury. You might regard it as a slightly strange thing to call it because the kidneys haven't been injured. Yes, kidney function has acutely gone down, but it's not actually due to a kidney injury. So why are we calling this an AKI? Well, it's just terminology. It used to be called acute renal failure, which would have probably been a better name for dehydration-induced AKI because, of course, it is renal failure. The kidneys are failing to get rid of the waste products. They're failing to do their job because of the dehydration. But of course, we've dropped that name, acute renal failure, and we've replaced it with acute kidney injury. So it's just terminology. You may think it sounds strange because the kidney hasn't actually been injured in this case, but that's what we've got. That's how we refer to it. So dehydration can produce an acute kidney injury, and that is counted as a pre-renal cause because it's nothing to do with the kidneys. It's a systemic problem. Sepsis-induced AKI. This is going to take a little bit more explanation because I'm going to have to talk about what is sepsis, which is a fantastic question. I could make an entire video on what is sepsis. So, briefly then, sepsis is where you are very, very unwell because of an infection of the body. It is very related to the old term septicemia. We don't use this term that much anymore. We've replaced it with sepsis. Septicemia used to mean blood poisoning, and often when we do use the word septicemia nowadays, we mean actually where an infection is in the bloodstream and it is dividing in the bloodstream. So it's where you've got an infection so badly that it's present within the bloodstream and it's taking over the bloodstream. Sepsis is slightly broader than that. And this is something I really want to impress on you. Sepsis is not where the infection is necessarily in the bloodstream. If the infection is in the bloodstream, then that is most likely sepsis, but it doesn't have to be in the bloodstream to be sepsis. Often we now use this old term, septicemia, to mean that the infection is actually present within the bloodstream, but we avoid that term quite often. Sepsis is where you have a bad enough infection that the body's immune response has got so out of control that it is now causing all sorts of tissues all over the body to misfunction. So let me explain this in a little bit more detail, and I think I'll draw a little picky. So, let's say, here's a picture of the lung, or lungs, I'll make it both of them. So we have right and left lung, and let's say we have a bad infection in one of the lungs. So we have pneumonia here. So this patch of pink, this is representing an infection of that portion of the lung, and it's community-acquired pneumonia, a very common, very serious infection that affects generally older people. This is a very bad infection, and of course what's going to happen in response to the infection is a huge amount of inflammation is going to occur at the site here. So all the capillaries are going to respond, they're going to bring out fluid from the bloodstream into the area and bring out white blood cells. But what coordinates that inflammation? Well, remember your preclinical science. Inflammatory mediators, inflammatory cytokines, special proteins and other molecules that are pro-inflammatory are released by tissues which are infected by bacteria or by other pathogens. And these are what tell the capillaries in the local area to initiate the inflammatory response and bring in proteins from the bloodstream and white blood cells from the bloodstream into that area. Now, when you have a really horrendous infection, so many cytokines and other inflammatory molecules can be produced that the levels of them within the bloodstream go dangerously high. And this is believed to be crucial to the pathology of sepsis. So if you've got such a bad infection that cytokines within the bloodstream go too high, and I'm just going to make a little diagram of what's happening. So infection, abbreviation is INFXN. So really bad infection can cause cytokine level within the bloodstream, and I'm specifically being broad here because there are so many different cytokines, too many to list here, too many of these different types of pro-inflammatory molecules, so we're just broadly putting them all under this heading, cytokines. The levels of these pro-inflammatory cytokines can go up and up and up in the bloodstream, and when they get to too high levels, it can start affecting tissues all over the body. Unfortunately, this just seems to be where our bodies are not perfect. The inflammatory response, when it is on a low level, is brilliant. It gets rid of infections, and the systemic cytokines cause our body temperature to go up, and our heart rate to go up, and our blood pressure to be maintained, and it all works brilliantly. Unfortunately, if you push it too hard, if you get a too severe infection and cytokine levels go too high, it breaks. These cytokines start having signaling effects that they shouldn't have. Our bodies are not perfect. Evolution or intelligent design, whichever one you want to believe, did not make it perfect. It made it breakable. And when the cytokine levels go too high within the bloodstream, many tissues all over your body start misfunctioning. So the brain starts misfunctioning. You go into an altered mental status. You become confused, drowsy. You may even start having seizures. Other tissues, in particular your kidneys and your liver, can start misfunctioning, and that is what sepsis-induced AKI is. It is a problem with the function of the kidneys that is induced by this sepsis state, this too high levels of cytokines being within the bloodstream. So I hope I've kind of explained to you what sepsis is. It's an infection, a really bad infection, that has now led to your body starting to break effectively, and it isn't necessarily the infection that's directly causing it. It's the inflammatory response, and the levels of inflammatory cytokines within the bloodstream have now got so high that they are starting to actually break your body. So I hope you understand that it's different to this concept of septicemia, which we now use as a word to mean infection within the bloodstream. You don't necessarily have to have the infection actually present within your bloodstream to become sepsis. Often if you do have the infection in your bloodstream, then that's a horrendous infection and it causes this cytokine storm, and therefore you are septic. But it's not necessary. The infection could still be in a local tissue such as the lungs and just be causing a cytokine storm within the bloodstream that is leading to the sepsis. So that's what sepsis is, such a bad infection that the immune system has become so overactivated that it's starting to cause havoc all over the body. And one of the areas where it causes havoc is the kidneys, and this is the so-called sepsis-induced AKI. And this is a massive cause of AKI in hospitals because, of course, many of the people in hospitals have got severe infections such as pneumonia and have become septic with those infections and have developed sepsis-induced AKIs. Just a little bit of an understanding about what is happening in sepsis-induced AKI. So just let me draw a little picture of a nephron, and it's going to be a really basic picture of a nephron. So there's the Bowman's capsule, proximal convoluted tubule, loop of Henle, distal convoluted tubule, and then the collecting duct. So, of course, you will know your basic renal physiology. Glomerular filtrate is produced here, and that fluid moves all the way through these tubes, and a tiny bit of it, a tiny fraction, about 1%, maybe even less than 1%, will make it down to the end of the collecting duct and actually become urine. The question is, what actually makes all of that fluid move through the renal tubules? Have you ever wondered that question? Why does it continue moving through the renal tubule like that? Well, one of the answers is that on the surface of the tubule cells that line the tubule, there are little cilia, little projections into the lumen that beat and help to move the fluid along. What we think happens in sepsis is that the cytokines, the systemic cytokines, start having signaling effects on the renal tubules, and they start making the cells misfunction, and one of the manifestations of this is that the cilia stop beating, they stop working properly, or maybe they start beating in a disorganized fashion and therefore sending the fluid back the other way. And this leads to the whole nephron basically shutting down, because if the cilia don't beat properly, the fluid's not going to be moved through, and therefore the whole thing's going to stop functioning correctly. That's what we think underlies sepsis-induced AKI. However, it's still controversial, the mechanism. However, what we do know is that many people who become septic, who get sepsis, their kidneys start shutting down, and that this shutdown is reversible. So loads of nephrons start functioning at a suboptimal level, and this reduction in function is reversible, and we think it may be caused by the cilia on their luminal surfaces not actually functioning correctly because of the mess that is the signaling that is occurring from these cytokines that are at such elevated levels within the bloodstream. So, two phenomenally important causes of acute renal failure or acute kidney injury then, dehydration and sepsis-induced AKI, and those two are so common and you must think of them before you think of anything else because they are most likely to be the answer as to why your patient has an AKI. However, they do not represent diseases of the kidney, they represent systemic diseases that are leading to acute renal failure. However, we don't like using acute renal failure, so we call it an acute kidney injury despite the fact that the kidney has not actually been injured in these cases. And if you get better from the infection, which happens in many cases, your cytokine levels will go down thanks to the miracle of antibiotics. Your cytokine levels will go down and then your renal tubules hopefully will start functioning correctly again and you'll get better. Right, so that's pre-renal done then. Let's go on to intrarenal. So, as I said at the beginning of this second part of the video, there are three major different classes of intrarenal disease. So we're going to have further categorization now. And these are glomerulonephritis, a massive great word, that means inflammation of the glomerulus and the glomerular basement membrane, and often the Bowman's capsule. So it means inflammation of this starting point of the nephrons. And there are a huge number of different causes of glomerulonephritis that we will go through, despite the fact that they are all phenomenally rare. But we'll come on to that in a moment. Next, second category is interstitial nephritis, that is inflammation of the interstitium between the nephrons. And again, there are different causes of this, and we'll come on to those later on. And then there's the most common cause of intrarenal disease, because both of these are quite rare. And we'll abbreviate interstitial nephritis down to IN. So the most common, but still rare compared to the pre-renal causes of AKI, the most common cause of intrarenal AKI is tubular necrosis. And if it's an acute tubular necrosis, we would call it acute tubular necrosis, which is where cells of the renal tubules die for some reason, and we'll talk about the different reasons later on. So, three major categories then of intrarenal disease: glomerulonephritis, some inflammation of the glomerulus and the glomerular basement membrane and the Bowman's capsule up here of all the nephrons; interstitial nephritis, inflammation of the interstitium between the nephrons; tubular necrosis, where for some reason the tubule cells are going to die or be damaged hugely. Right, so warning, this is going to get complicated. We're going to talk about a huge number of very rare, very serious diseases, but they are very rare, thankfully, and we're only going to scrape the basic top surface of knowledge about these different diseases, and they're all different causes of glomerulonephritis, and they've all got massive, great big names. So, with a warning of we'll get through this together, let us now talk about the different causes of glomerulonephritis, and we'll do it here. We'll come back to the other things. So, glomerulonephritis. How do you categorize the different causes of glomerulonephritis? So, the main way is that we divide it firstly into two different categories, which are non-proliferative glomerulonephritis and proliferative glomerulonephritis. So this is the first categorization, that we can split different forms of glomerulonephritis into these two separate categories. So what does it mean? So, glomerulonephritis, as I said, it's inflammation of the glomerulus, usually in particular the glomerular basement membrane, and often the Bowman's capsule. So I think for this discussion we're going to need another picture of the renal corpuscle here. So let's just draw this here. So here is Bowman's capsule and the beginning of the renal tubule here. And let me try and draw you a better glomerulus this time. I'll get a less thick pen. So here is the afferent arteriole, and then here we have our glomerular capillaries. There's one anyway, and efferent arteriole, another glomerular capillary here, third one, and we'll have a fourth one. Right, so glomerular capillaries, efferent arteriole, afferent arteriole, and the glomerular basement membrane is in between the capillaries and the beginning of the Bowman's capsule here. So in glomerulonephritis, you're going to get inflammation of the glomerulus, inflammation of the glomerular basement membrane, and inflammation of the Bowman's capsule in many cases as well. Also, be aware that there are some special cells, or there's a special area of tissue that's in between the different glomerular capillaries. So you can see we've got a bunch of glomerular capillaries here. There is going to be spaces in between the glomerular capillaries, and also some spaces in between the glomerular capillaries and the surface of the Bowman's capsule here. That's known as the mesangial tissue, so I'll put that fancy word there. And there are actually a few little cells. Whoops, we need to thin up the pen. There are actually a few little cells in there known as mesangial cells. So it's also inflammation of the mesangial tissue, or the mesangium as well. So that's where you're going to get inflammation occurring in glomerulonephritis. And this could occur in a huge number of the different nephrons of your two kidneys. And you can imagine that when this occurs, it's going to massively destroy temporarily the renal function. Those nephrons that this has occurred in, it's going to massively affect their function. So if it occurs in a huge number of nephrons, renal corpuscles, which is the name, by the way, for the Bowman's capsule and the glomerulus together, the renal corpuscle, if that occurs in a huge number of them, then you can imagine that renal function is going to massively deteriorate and you're going to get an acute kidney injury. Now, coming back to our categorization of proliferative versus non-proliferative, inflammation, you'll remember that it consists of two major parts: bringing in proteins from the bloodstream that can attack pathogens, such as the complement proteins, and bringing in cells, white blood cells, from the bloodstream into the tissue so that they can attack pathogens. In non-proliferative glomerulonephritis, which is more mild glomerulonephritis, you just get the protein component coming in, but you have not got more cells present. There aren't more cells present in the mesangium and in the Bowman's capsule, so white blood cells have not come in, and that's why we call it non-proliferative, because the number of cells has not gone up. So no white blood cells in this case. In proliferative glomerulonephritis, the number of white blood cells does go up, number of cells in the renal corpuscles go up. So white blood cells have come in as well as proteins. So proliferative glomerulonephritis is worse than non-proliferative glomerulonephritis. And I should say that the way in which you distinguish between these different forms that I'm about to tell you of glomerulonephritis that come under each of these headings, non-proliferative and proliferative, it's done by very, very clever people, histopathologists. And in order to make these sort of diagnoses, you need a renal biopsy. So you need to have put in a little needle into one of the kidneys. Usually they go through the back. They put in a little needle, take a little sample of tissue, and send that off to a clever histopathologist to look under the microscope, and they can actually look at the renal corpuscles and look for this inflammation, and they can say, are there more cells present or not, in which case it comes under the category of proliferative. If there aren't more cells, then it comes under the category of non-proliferative. So that's what these two categories mean. So here comes the scary bit now. So under non-proliferative, there are three further categories of glomerulonephritis. So the first, if I thins down the pen, yeah, it's fine. The first is minimal change disease. The second is focal segmental glomerulosclerosis. And the third is membranous glomerulonephritis, MGN for short. Under proliferative glomerulonephritis, there is membranoproliferative glomerulonephritis, MPGN for short, and then there is rapidly progressive glomerulonephritis, RPGN for short, which is also called crescentic glomerulonephritis. So let me try and talk you through this. So again, let me stress that these different diagnoses of glomerulonephritis, they are made by histopathologists. Glomerulonephritis is fundamentally inflammation of the renal corpuscles, inflammation of the glomerulus, the glomerular basement membrane, the mesangium, and maybe the basement membrane. When you take a renal biopsy, the histopathologist can look at it underneath the microscope and they can further categorize it depending on how bad the inflammation is. That is what this is. These 5 different categories, they are where a histopathologist has looked at it and graded how severe it is, And we categorize these 5 different categories into these broader categories of non-proliferative versus proliferative, but fundamentally it's all glomerulonephritis, inflammation of the renal corpuscle. Let me now talk about the histological features, the basic histological features of these different categories, and beware that I am not a histopathologist, so I am not an expert at doing this, but I can give you the basic gist of how they differ between one another. So let's start with minimal change disease. So I will write down its name in full so that you know how to spell it. So MCD stands for minimal change disease. And you can probably guess by the name what the histological feature of minimal change disease is going to be. Minimal change disease is the most mild form of glomerulonephritis. When a histopathologist looks down the microscope at a renal corpuscle that has been affected by minimal change disease, they see minimal change. That's where the name comes from. So there's very little change to see in minimal change disease. So it's the mildest form. And the cause of minimal change disease is different to the causes of some of the more severe forms of glomerulonephritis. So what we're going to see actually is that these 3 forms, the more severe forms, membranous glomerulonephritis, membranoproliferative glomerulonephritis, and rapidly progressive glomerulonephritis, they are all grouped together, and I might even actually draw this in preparation. So these 3 forms of glomerulonephritis, these are all going to be grouped together because they're actually, the causes of them are all the same. The diseases that can give rise to them are all the same. They're just different severities of the same diseases. So this one being the least severe, this one being the medium severity, and this one being the most severe inflammation. Whereas these 2 different histological appearances over here, these are separate diseases. They're not caused by the same diseases as cause these ones. And these are generally milder. So minimal change disease is actually a disease in its own right. It's a form of glomerulonephritis, a very mild form of glomerulonephritis that is idiopathic. We do not know why it occurs, and it classically presents with nephrotic syndrome rather than acute kidney injury. However, it can cause an acute kidney injury. Or if it were to cause an acute kidney injury, it would commonly cause both nephrotic syndrome and an acute kidney injury. So, let me summarise then what we know about minimal change disease. It's idiopathic. We do not know why it occurs. So it occurs in random people. If you take a biopsy of a renal corpuscle, you cannot actually see that much difference. But what has happened is some sort of inflammation of the glomerular basement membrane that has damaged the glomerular basement membrane enough that now albumin can leak out of the capillary lumens and into the Bowman's capsule, so you can get nephrotic syndrome. In addition, in some cases, although it's rare, the damage to the renal corpuscles can be bad enough to cause an acute kidney injury. So I'll put this here. This is nephrotic syndrome, possibly an acute kidney injury. But this is a separate disease in its own right. It's a disease entity as well as a histological appearance. So it is a diagnosis, not just a histological appearance. These 3 over here, as we'll see, these are not diagnoses. These are histological appearance, and there's a huge number of different diseases that I'm going to list down here that can give rise to their different histological appearances. Right, so that's minimal change disease. Let's now do focal segmental glomerulosclerosis. So again, I'll write it down so that you can learn how to spell it. So F is for focal, S is for segmental, and then GS is for glomerulosclerosis. One great big word. Okay. Now, firstly, what does glomerulosclerosis mean? Sclerosis means hardening. Glomerulo refers to the glomerulus. In glomerulosclerosis, and it's a word that we will actually see later on as well, because when we come on to CKD and discuss diabetic nephropathy, this is what happens in diabetes as well, diabetic glomerulosclerosis. This is separate, however. Glomerulosclerosis means that the glomerular basement membrane for some reason has become much, much thicker. Scar tissue has been set down in the glomerular basement membrane, so it becomes much more thicker. Loads more connective tissue has been laid down. And this, again, can lead to two things. It can lead to classically nephrotic syndrome, but it can also lead to AKI, so I'll put this down as well. So this again is believed to be an inflammation of the glomerular basement membrane. Oops, I meant to write nephrotic syndrome first. And it again, even though the glomerular basement membrane is going to become thicker, it isn't as good quality tissue that's being laid down there after the inflammation. So again, it can still leak and leak albumin out, and therefore you can develop nephrotic syndrome. In addition, the thickening can result in misfunction of the nephrons that are affected, so reduced function of those nephrons. Even though they're leaking albumin, the amount of glomerular filtrate might still be less. So you can get an AKI, but it's rarer. The main presentation of focal segmental glomerulosclerosis is nephrotic syndrome. What is the focal segmental about? So focal segmental means that the glomeruli that are affected are not diffusely spread out in the kidneys. So again, focal segmental glomerulosclerosis is not particularly well understood, but actually it affects patches of the kidneys. So if I was to draw a little picture of the kidneys, and it's probably a good idea if I actually do, so let's just have a picture of one of the kidneys, a very basic picture of a kidney and a ureter there. If we were to look at the patches that were affected by it, it comes in little patches like so. So the nephrons in this patch of kidney that I've coloured in pink here, they might be affected by focal segmental glomerulosclerosis, so their glomerular basement membranes might be massively thickened because of an inflammatory process, whereas the patches that are in between, they might be unaffected. That's what focal segmental means, that it's not a diffuse disease of the kidneys, it's a focal disease that affects little segments of the kidneys. Now, unlike minimal change disease, we do actually know some of the causes of focal segmental glomerulosclerosis. It can occur in people who have HIV. So in people who are HIV infected, for some reason, this can occur as a phenomenon of that. We call it HIV nephropathy. Also, in people who use heroin for a long period of time, this is a horrible consequence of heroin use, that they can develop focal segmental glomerulosclerosis independent of whether they develop HIV because of their intravenous drug use. So those are two acknowledged causes of focal segmental glomerulosclerosis. So let me summarise what I've told you so far about these two causes of glomerulonephritis, because they are separate to what we're going to discuss next. So, glomerulonephritis, inflammation of the renal corpuscles. We've divided it into non-proliferative and proliferative, and under those two headings, we have these three different histological appearances: minimal change disease, focal segmental glomerulosclerosis, membreless glomerulonephritis, membranoproliferative glomerulonephritis, and rapidly progressive glomerulonephritis. These three are just that. They are histological appearances, and they are all caused by the same great big long list of diseases that I'm about to go on to. They are just different severities of kidney disease because of those diseases. So these aren't diagnoses, they are just histological appearances. Whereas these two, they are histological appearances, but they are also diagnoses. Minimal change disease and focal segmental glomerulosclerosis, they are diagnoses, they are diseases in their own right that cause glomerulonephritis. Minimal change disease is idiopathic inflammation of the glomerular basement membrane that causes it to become leaky, classically presents with nephrotic syndrome, possibly can cause an acute kidney injury, and it's treated with steroids. Focal segmental glomerulosclerosis, not idiopathic. We do know reasons such as HIV infection and heroin use. It's a thickening of the glomerular basement membrane. Scar tissue is being laid down because of presumed inflammation. It affects focal segments of the kidneys, classically presents as nephrotic syndrome, so the glomeruli that are affected become leaky, but can also cause an acute kidney injury. So those nephrons that are affected, their glomerular filtration rate can be reduced, and therefore overall kidney function, if enough nephrons have been affected, can go down significantly, and you can start developing the problems of an acute kidney injury. Alright, let's now go on to the next bit, and here we go. These diseases are rare, by the way. We're now going to go on to some diseases that are even more rare, that are autoimmune diseases. So, these three things then, membranous glomerulonephritis, membranoproliferative glomerulonephritis, and rapidly progressive glomerulonephritis. And I will, just to be fair to them, write out their names so that you know how to spell them. So MGN is membranous, MPGN is membranoproliferative. I'm going to need a little bit more space for this one. Membranoproliferative, because of course it's now a proliferative glomerulonephritis, where you're getting increased white blood cells present. And then finally, rapidly progressive, hopefully you know how to spell that, but I will write it down anyway, rapidly progressive glomerulonephritis, or crescentic. So these are all caused by the same list of diseases. This one is the least severe, where you've got inflammation occurring, but it's just proteinous inflammation, not white blood cells coming in. This one is then more severe because you're getting white blood cells. So you'll see white blood cells in the mesangial tissue area that have come into that basement membrane area. Rapidly progressive glomerulonephritis, also called crescentic, is the most severe grade of this disease. And the reason it's called crescentic is that the Bowman's capsule will end up completely full of inflammatory exudate and white blood cells. So you'll end up with loads of white blood cells here, and you can imagine that that forms a crescent of white blood cells. So that's why it's called crescentic, because you see crescents of leukocytes effectively in the kidney tissues, and these represent the Bowman's capsules that are now absolutely full up of white blood cells and inflammatory exudate. So let's now talk about the diseases that can cause these three different histological appearances. And as I said earlier on, I'm not a histopathologist, so I'm just giving you the basic gist of the histological difference. I don't expect you to, after watching this video, suddenly be able to look at a slide, a microscopy slide of a kidney, and tell me which one of these five it is. It's just to get the basic idea, which is all you need if you're not going to become a histopathologist. So the diseases then that can cause this, there's a great big long list, so we categorise them further. So we're going to categorise them into type 1, type 2, and type 3 causes of glomerulonephritis. So we'll begin with type 1. And as I said earlier, these are generally rare autoimmune diseases. And they've all got very big, fancy names, and we're just going to skim over the surface of knowledge about these diseases. So type 1 then. Type 1 is a disease known as Goodpasture's disease, also called anti-GBM syndrome. So Goodpasture's disease is the old name for it, also called Goodpasture's syndrome. The newer name is anti-GBM syndrome. And GBM, of course, stands for glomerular basement membrane. So this is an autoimmune disease where, for some reason, the poor individuals that develop this develop antibodies that are directed against a certain protein that is used to make the glomerular basement membrane. Hence the name anti-GBM syndrome, because you're producing anti-GBM antibodies, anti-glomerular basement membrane antibodies. So when you produce these antibodies, what of course is going to end up happening is they're going to end up binding to the glomerular basement membrane, and then they will trigger inflammation to occur there. And depending on the severity of the inflammation, it will determine whether the histological appearance is membranous glomerulonephritis, membranoproliferative glomerulonephritis, or rapidly progressive glomerulonephritis. Other thing to know about this disease, these same antibodies that can bind to the glomerular basement membrane, they can also bind to the basement membrane that the pneumocytes in the lung sit on. So remember, in the lung, the tissue consists of loads of alveoli, and the epithelia of those alveoli, those epithelial cells, are called pneumocytes, and they sit on a basement membrane as well, and underneath that basement membrane is where the capillaries that are going to exchange gases are present. Now, unfortunately, these antibodies can also bind to the protein that is present within those basement membranes. So this protein that this is directed against is present not only in the glomerular basement membrane, but also in the basement membrane of the alveoli in the lungs. And therefore, you also get diffuse inflammation present within the lungs as well. And this can make you give you pulmonary symptoms, respiratory symptoms as well, such as shortness of breath and coughing up blood, things like that. So Goodpasture's disease is one of these diseases, and there are two major diseases, the other one of which we're going to see later on when we discuss type 3. It's one of these diseases that hits the kidneys and hits the lungs. So that's Goodpasture's disease. It can present with a multitude of different things. It can present with an acute kidney injury because the glomeruli of the nephrons that are affected are no longer going to function correctly, and therefore kidney function can suddenly drop. It could also potentially present with nephrotic syndrome, where it damages the basement membrane enough that albumin can now leak out, and if you lose enough albumin, you're going to get the third spacing of nephrotic syndrome. And also, I promised that I was going to mention when nephritic syndrome is a relevant description if you really want to use it. This could be bad enough to actually break the basement membrane so much that now blood can leak out into the Bowman's capsule, and therefore you can get hematuria in Goodpasture's syndrome, so you may well end up with a nephritic picture as well. So I'll write some of this down. So AKI most definitely, nephrotic syndrome, and also, even though I'm begrudged to write it, nephritic there as well. It can also give rise to the hematuria. So it can make you bleed from your kidneys and bleed from your lungs. That's classic medical school question. If you see lungs, hemoptysis and hematuria, there are two diseases that you should instantly think of. Goodpasture's is one of them. Wegener's granulomatosis, which we'll come to when we discuss type 3, is another one. Also be aware, we'll discuss CKD later on, that all of these diseases that can cause AKI, they can cause recurrent AKI, and if they go on for long enough, they're going to permanently damage those nephrons and they're going to be replaced with scar tissue, and therefore they can lead to you developing CKD. But we'll discuss that more when we go on to discuss CKD. So type 1 is just Goodpasture's disease that's underneath that, or anti-GBM syndrome. Now let's talk about type 2 glomerulonephritis. So type 2 glomerulonephritis includes the immune complex deposition diseases, and there are loads of these. So these are diseases where you get a huge number of immune complexes circulating within the bloodstream. And the important thing about this is that these immune complexes can deposit in certain tissues, and one of the tissues where they can deposit is the glomerular basement membrane. They can try to get filtered by the glomerular basement membrane, and then they end up getting stuck within the basement membrane, and then they cause inflammation. So I'll just remind you of what an immune complex is. So an immune complex is a complex between an antibody, that's the antibody molecule, and the antigen against which it is targeted. So that's what is meant by an immune complex. When you've got an antibody bound to an antigen, that's an immune complex. So in immune complex deposition diseases, you're going to get high levels of circulating immune complexes. These can then deposit in different tissues. The one that we're interested in here is the glomerular basement membranes. When they get stuck in the glomerular basement membranes, they'll trigger inflammation, and that is going to be a glomerulonephritis, specifically a type 2 glomerulonephritis, and depending on its severity, it will have one of these three histological appearances. So examples of immune complex deposition diseases, the classical one is lupus, systemic lupus erythematosus. Lupus is a horrible autoimmune disease where you produce antibodies against nuclear antigens that are inside the nuclei of all of your cells. We do not understand why it occurs, but it leads to a huge number of circulating immune complexes where you've got these autoantibodies, these anti-nuclear antibodies as they're called. That's the classic test that we do for lupus, anti-nuclear antibodies, ANA. Bound to their nuclear antigens and circulating within the bloodstream. So they can lead then to immune complex deposition in the glomerular basement membrane and type 2 glomerulonephritis. And that's one of the most serious manifestations of lupus. It has a huge number of different manifestations, but when it affects the kidneys, that's when we take this disease extremely seriously, because it could lead to permanent damage and CKD. So lupus. Another one is post-streptococcal glomerulonephritis, PSGN for short. So I'll just write that out again so you can spell it. So the PS is for post-streptococcal. Now, this is a rare consequence of an infection by a form of streptococcal species, namely the species Streptococcus pyogenes. Now, strep pyogenes can cause a number of different infections, but the classical one that it can give rise to is something called strep throat, which is an extremely sore throat infection. Now, most throat infections, everyone gets throat infections from time to time. Most throat infections are caused by viruses. Bacterial throat infections are much, much rarer. They're generally much worse. They hurt a lot more. They don't have the cough. If it's a virus, this is one of the key ways that you can distinguish between bacterial pharyngitis and viral pharyngitis. If it's a virus, it infects other portions of the respiratory tract as well. So it'll infect their nose and give them coryzal symptoms. It'll infect the larynx and the first part of the trachea and give them a cough. If it's a bacterial pharyngitis, it doesn't infect those other portions, and therefore you just get a sore throat. You also will classically get a very high fever in bacterial pharyngitis, which you might not get it if it's a viral sore throat. The lymph nodes in the neck go up, the tonsils can often swell, and you can get exudate on the surface of the tonsils. And these are the sort of things that would point you towards maybe this person's sore throat isn't just a virus, maybe it's strep throat. It does occur sometimes, strep throat, but as I say, most people's sore throats, everyone gets sore throats, and they're usually viral sore throats rather than bacterial. However, strep pyogenes can cause sore throats. It can also cause skin infections, so it can cause impetigo, which is a skin infection that commonly affects children. Staphylococcus aureus is usually the cause of impetigo, but strep pyogenes can also cause that. Cellulitis, again, usually staph that causes that, but streptococcal pyogenes is also a known cause in some cases. So, you get an infection with this bacteria. One of the rare consequences of infection with this bacteria is that you get circulating immune complexes where you've produced antibodies against an antigen of this bacteria, and then they're bound to an antigen. We don't know whether it's an antigen of the bacteria or whether it's an autoantigen. It possibly is an autoantigen. So this possibly represents an autoimmune disease. And when you have those circulating immune complexes, again, you can get immune complex deposition in the glomerular basement membrane and therefore type 2 glomerulonephritis. So to summarize that again, streptococcal pyogenes infections are nasty. They can have a number of very serious consequences. Some of the other ones are scarlet fever and rheumatic fever, rare consequences following these infections. But post-streptococcal glomerulonephritis is one to be aware of. We believe that what happens in some individuals when they have this infection, they produce antibodies, a certain type of antibody against this bacteria, against an antigen of this bacteria, and we think it probably then happens that it's capable of binding to some autoantigen. So the infection, we think, can trigger an antibody to be produced that cross-reacts with an autoantigen. Then you end up, again, with circulating immune complexes that can then deposit in the glomerular basement membrane and cause post-streptococcal glomerulonephritis. So that's post-streptococcal glomerulonephritis. Two other immune complex deposition diseases, and I'm going to talk about these two together. So IgA nephropathy is one, and then there's what is believed to be the systemic form of IgA nephropathy, or the wider spread form of IgA nephropathy, that is Henoch-Schönlein purpura, which is HSP. So let me just concentrate on spelling this. Henoch-Schönlein, it's got that funny thing where you've got the two dashes above the O rather. So Henoch-Schönlein purpura, so HSP. So these two are believed to be very much so related to one another. They're believed to be problems with the production of IgA. So in people with these diseases, and they are believed to be genetic diseases, you produce a form of IgA where the constant portion of the IgA, so if we look at our picture of the antibody, remember IgA is a form of immunoglobulin, a form of antibody that has a certain constant region here. So the different forms of immunoglobulin, IgG, IgA, IgM, IgE, remember they differ in the constant region of the antibody here. So IgA has a certain constant region structure, and in people with these diseases, we believe that the constant region structure that they have for IgA is unfortunately capable of having an autoimmune disease produced against it. So unfortunately, it's capable of having other antibodies produced against it, which will be of the IgE form. So let me just draw this here. So if this is the IgA molecule, in people with Henoch-Schönlein purpura, their immune system is capable of producing let me reverse that. Their immune system is capable of producing, no, I've messed this up slightly, let me try and correct it. So pretend that that one was meant to be the light chain. So their immune system is capable of producing antibodies that are capable of binding to the constant region of the IgA molecule here. So this is our IgA molecule, and this will be an IgG molecule. So it's an autoimmune disease against your own antibodies, against specifically IgA antibodies. Now, IgA is the form of antibody that you produce to be secreted onto epithelial surfaces, so the respiratory tract epithelial surface, the gastrointestinal tract epithelial surface, the urinary tract epithelial surface. So it's produced in response to infections in those areas, or at least the production of it's going to go vastly up in response to infections in those areas. So these two diseases, often the relapses in them are triggered by an infection of one of the epithelial surfaces. So let me explain how it works. If you get, let's say, a chest infection, IgA production is going to go hugely up because of that chest infection, because this is the form of antibody that we can secrete onto our epithelial surfaces. Remember, IgG and IgM, they stay in the extracellular fluid. IgG can go into the extracellular fluid outside of the bloodstream, and it can remain in the bloodstream. IgM remains solely in the bloodstream. IgA is the only one that you can secrete actually onto epithelial surfaces. So when you get a chest infection, you're going to produce a lot more IgA, but now we've got our IgG that can bind to the constant region of IgA, so you're going to end up with a huge number of these immune complexes of anti-IgA antibodies bound to IgA circulating within the bloodstream. These can deposit in different tissues. In IgA nephropathy, it seems that they only deposit in the kidneys, in the glomerular basement membrane, and this can result in a massive type 2 glomerulonephritis. In Henoch-Schönlein purpura, it seems that they are capable of depositing not just in the kidneys, but in other areas as well, classically in the skin. And when they get deposited in the basement membrane of the capillaries in the skin, they can cause inflammation of those capillaries, which can cause those capillaries to bleed, and then you can end up with small little bleeds in the skin, and that is what purpura is. And classically in Henoch-Schönlein purpura, it affects the legs and the buttock regions more than any other area of the body. Now, you might think Henoch-Schönlein purpura sounds worse than an IgA nephropathy, but actually it's the other way around. In this disease where the immune complexes are capable of depositing in other areas, it means that less of them end up depositing in the kidneys. And depositing in the skin, maybe it looks unpleasant and it looks scary, but actually depositing in the kidneys is much worse, because you cannot live without your kidneys. If your kidneys get damaged and the damage is permanent, you are approaching real problems. So actually, Henoch-Schönlein purpura is the milder form than IgA nephropathy, because the progression of the kidney disease is slower in Henoch-Schönlein purpura than IgA nephropathy, because of the fact that the immune complexes deposit in other areas besides just the kidneys, whereas in IgA nephropathy they just deposit in the kidneys, and therefore they can cause much worse glomerulonephritis. So, these two diseases then, IgA nephropathy and Henoch-Schönlein purpura, Can I retract the statement that I made earlier about them being genetic diseases? I'm not sure they are genetic diseases, not at least in the Mendelian way. They're not genetic diseases. They, of course, will have a huge number of genes that are associated with them, but they're certainly not Mendelian genetic diseases. They represent an autoimmune disease where you produce autoantibodies against the constant region of your IgA antibodies, and therefore you get exacerbations of them when you produce lots of IgA, which is when you get epithelial infections. The most common epithelial infection would be chest infections or gastrointestinal infections. IgA nephropathy, these immune complexes are going to deposit in the kidneys. And by the way, of course, I said that IgA, it's going to go to the epithelial surfaces, but of course it's going to be produced by plasma cells in the bone marrow, and therefore it firstly goes into the bloodstream and then it will be secreted onto epithelial surfaces. So of course, whilst it's in the bloodstream, then these IgG molecules that are targeted against the constant region of IgA can bind to it. So you'll get these immune complexes circulating in the blood. In IgA nephropathy, they're going to deposit solely in the kidneys and can cause very, very bad glomerulonephritis, rapidly progressive glomerulonephritis potentially, which can lead to massive kidney damage. And henoch on the imperpurate, they can deposit elsewhere as well, and this means that the progression of the kidney disease is slower. So all of these diseases then, they're all immune complex deposition diseases. The fundamental pathology is the same, immune complex deposition in the glomerular basement membrane leading to glomerulonephritis. They can present as AKI, nephrotic syndrome. Again, they could produce bad enough damage to the glomerular basement membrane that you could get a nephritic picture where you're getting hematuria in the blood as well. And if they go on for long enough, they're going to lead to permanent destruction of nephrons, replacement by scar tissue, and therefore they're going to progress to CKD. So that's type 2 glomerulonephritis. We'll have a break after we've discussed type 3 glomerulonephritis. So type 3 glomerulonephritis, more rare diseases. So type 3 glomerulonephritis consists of the ANCA vasculitides. So vasculitides is the plural for vasculitis. Vasculitis is inflammation of blood vessels. The ANCA vasculitides, and there are 3 of them, they are autoimmune diseases that we don't know that much about, but they're autoimmune diseases of capillaries, and they can affect, unfortunately, the glomerular capillaries and therefore lead to glomerulonephritis. ANCA, what does ANCA stand for? ANCA stands for anti-neutrophil cytoplasmic antibody. So anti-neutrophil cytoplasmic antibody. And no one really understands why these antibodies, these ANCA antibodies, are actually associated with these diseases, but they are. So these are horrible autoimmune diseases of capillaries, the ANCA vasculitides. There are 3 of them, and they can all affect the glomerular capillaries. We do not really understand what the target for the autoimmune diseases in the ANCA vasculitides is. Despite that, clever people have managed to find antibodies that are associated with the disease, and these are called the ANCA antibodies, the anti-neutrophil cytoplasmic antibodies, but we do not understand why these antibodies that can bind to proteins within neutrophil cytoplasm are associated with these autoimmune diseases of capillaries. It does not make sense, and I'm afraid I cannot give you an explanation for that because it's not currently known. Come back in 50 years' time and we might actually have some answers, but at the moment these are extremely rare diseases and extremely poorly understood diseases. So that speech out the way, let's actually name the different ANCA vasculitides. So there are 3 of them. And their names, they have multiple names, 2 of them at least. So the first one is granulomatosis with polyangiitis. The second one is eosinophilic granulomatosis with polyangiitis. And the third one is microscopic polyangiitis. So let me write out one of their names. So granulomatosis with polyangiitis. GPA. Now, That is its new name. Its old name, which you will still hear used, is Wegener's granulomatosis. And I'm not going to write down granulomatosis again, so I'll just abbreviate it to G. We have moved away from the name Wegener's granulomatosis because unfortunately Wegener was a Nazi. He was one of these doctors who we think, well, I don't know that much about it, but I think he was one of these doctors who experimented on the victims of concentration camps. And for that reason, because he was involved in some of the worst evil mankind has ever seen, we do not want his name to be remembered, and therefore we have renamed this disease that was named after him granulomatosis with polyangiitis. But be aware that many people still call it Wegener's granulomatosis. EGPA is eosinophilic granulomatosis with polyangiitis. I'm not going to write down the full thing, I'll just write down the first bit. So eosinophilic, and then it's the same as before, granulomatosis with polyangiitis. This again had an old name, and I do not really know why we've dropped this name, because this name was not, as far as I know, the names of Nazis. It was Churg-Strauss syndrome. I don't think either of them were Nazis. But we have still renamed their disease eosinophilic granulomatosis with polyangiitis. Finally, this one, MPA, is microscopic polyangiitis. Okay, so all of these are ANCA vasculitides. They all have an ANCA antibody associated with them. Now, there are two different ANCA antibodies. There is C-ANCA and there is P-ANCA. C stands for cytoplasmic anti-neutrophil cytoplasmic antibody, and P-ANCA stands for perinuclear anti-neutrophil cytoplasmic antibody. GPA, granulomatosis with polyangiitis, is associated with the C-ANCA antibody, the cytoplasmic anti-neutrophil cytoplasmic antibody, whereas these two are associated with P-ANCA positivity, perinuclear anti-neutrophil cytoplasmic antibody. And again, I will stress, I cannot give you an explanation as to why these antigens that are in the cytoplasm of neutrophils have anything to do with autoimmune diseases against capillaries. All I can say is these are two separate antibodies directed against different targets. The target of C-ANCA is some sort of cytoplasmic antibody, whereas the target of P-ANCA is a cytoplasmic antibody that is very close to the nucleus. It's perinuclear. So, the final thing that I want to tell you about these different diseases is give you a little bit idea of the basic presentation that the medical student should be aware of about these. So how to differentiate between them. So granulomatosis with polyangiitis, let's start with this one, Wegener's granulomatosis, the C-ANCA positive ANCA vasculitis. This classically affects a huge number of capillaries. It classically affects the capillaries of the glomeruli of the kidneys and therefore can lead to a horrendous glomerulonephritis, usually rapidly progressive glomerulonephritis. So again, it could present with AKI, nephrotic syndrome, nephritic syndrome, and if it goes on for long enough, it's going to lead to CKD. But apart from the kidneys, what else can it do? Again, it can hit the capillaries in the lungs. So it can affect the capillaries, the pulmonary capillaries of the lungs. And when that happens, when you get inflammation of the pulmonary capillaries, that can lead again to bleeding of the pulmonary capillaries and hemoptysis, and of course also shortness of breath, because if you've got inflammation around the pulmonary capillaries, gas exchange is not going to be good. So again, hemoptysis can occur with Wegener's granulomatosis. So Wegener's granulomatosis, and I shouldn't call it that, granulomatosis with polyangiitis and Goodpasture's disease, they are the two diseases that you should be aware of that hit the kidneys and the lungs. If you ever, in a multiple choice question, it's more likely to be than in real life. If you ever have in a multiple choice question a patient that is peeing blood and coughing up blood, those are the two diseases you should think of, granulomatosis with polyangiitis and Goodpasture's disease. Also in granulomatosis with polyangiitis, it can affect the capillaries of the nasal epithelium as well, and therefore can lead to inflammation of those capillaries, and when they leak blood, that can lead to nosebleeds. So nosebleeds is another classic feature of granulomatosis with polyangiitis. So if you want the gist of GPA, it's renal failure, respiratory failure and coughing up blood, and nosebleeds. That is GPA in a line. Now, eosinophilic GPA, granulomatosis with polyangiitis, Churg-Strauss syndrome, again, it's going to hit your kidneys. So again, you're going to get renal failure. And again, it's very, very aggressive, can lead to rapidly progressive glomerulonephritis. But it also, in contrast to GPA, can result in inflammation of capillaries in the skin. And when that happens, they can break open and bleed, and therefore it, like henoch-Schönlein purpura, can lead to purpura all over the body. In addition, for reasons that we don't understand, in eGPA, you get an eosinophilia where the eosinophil level within the bloodstream goes right up as well. So in a line, eGPA is renal failure, purpura, and eosinophilia. Finally, microscopic polyangiitis, it usually is the mildest of the ANCA vascular disease, and it usually just affects the kidneys and causes renal failure, usually an acute kidney injury. But it's the mildest. If you had to have one of these horrible diseases, and they are horrible diseases, just to stress to you how severe they are, the life expectancy for GPA without treatment is about 12 months. You'll live for a year if you don't have treatment, because it destroys your kidneys, and once you have no kidney function, that's not compatible with life. So these are really, really severe diseases because of how destructive they are to the kidneys. MGPA is the least severe of them, it's the gentlest of them. So there we go, those are the three ANCA vascular disease, and we've now completed our discussion of glomerulonephritis type 1, type 2 and type 3, which can all give rise to these three different histological presentations depending on how severe glomerulonephritis they have caused. So I'd just like to summarise what we have seen here, because it is complicated. I hope we have got through it together. Understand that these diseases are all extremely rare and that they're not properly understood. So you only need to have the basic understanding of what they are and an awareness that they exist and that they are possibilities. It's far more likely that if a patient has an AKI that it's either dehydration or sepsis-induced AKI than these diseases. So type 1 was Goodpasture's disease or anti-GBM syndrome, where you produce an antibody that's directed against a protein within the glomerular basement membrane, and it hits both the lungs and the kidneys. Type 2 is immune complex deposition diseases, the four major examples being lupus, post-streptococcal glomerulonephritis, IgA nephropathy, and HSP. These all result in circulating immune complexes that can deposit in the glomerular basement membrane and cause glomerulonephritis. Type 3 are autoimmune diseases directed against kidneys that are very poorly understood and are very rare. These are called the ANCA vascular disease. They're associated with these bizarre antibodies, the ANCA antibodies, that we can do blood tests for. There are two of them, C-ANCA and P-ANCA. There are three diseases, granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, and microscopic polyangiitis. GPA is C-ANCA positive, whereas the other two are classically P-ANCA positive. They affect different ranges of tissues. They all affect the kidneys and cause quite bad glomerulonephritis, usually rapidly progressive glomerulonephritis. The way that you would distinguish between them is that GPA is by the other tissues that they affect. GPA classically affects the lungs as well, so be aware that it and Goodpasture's syndrome are the two that can hit both the kidneys and the lungs, but it also causes nosebleeds because of its effect on the nasoepithelium. eGPA will have an eosinophilia, hence why it's called eosinophilic granulomatosis with polyangiitis. So we can test for that when we look at the bloods in the when we do basic blood tests and look at the levels of different white blood cells in the bloodstream. But it also affects capillaries in the skin and therefore classically causes palpable purpura. MPA, microscopic polyangiitis, is the least severe of them all, and it classically just affects the kidneys. So in a few lines, that's how to distinguish between them. In reality, it's much more complicated, and many clinicians want to drop the distinction between the three anyway and just call them all ANCA vasculitis. Be also aware of these old names that they have, which we're trying to phase out. In particular, we're trying to phase out this one because of his involvement in a horrible part of history. Right, so we will have a break there, and in the next video we will continue with the causes of acute kidney injury. We'll go over interstitial nephritis, tubular necrosis, and the post-renal causes, and we'll also talk about nephrotic syndrome. Oh, before I do just finish this video, all of these horrendous causes of glomerulonephritis, they can cause nephrotic syndrome, they can cause acute kidney injury, they can cause a nephritic picture where you're bleeding blood from your kidneys, and they, over a long period of time, if you're suffering from glomerulonephritis caused by them, will lead to permanent loss of nephrons and therefore CKD.